Hello, my name is Yanelis Fernandez. I'm a PGY2 at the University of Miami-Jackson Health System, and I'd like to present the following presentation titled Altered Mentation in an Elderly Immunocompromised Patient on Belatacept. I'd like to thank Dr. Dango and Dr. Ortigosa-Coggins for their help in the editing process with this case report. So our case is an 82-year-old man with a history of kidney transplant on immunosuppression with belatacept, mycophenolate, and prednisone, who presented with 3 months of mental decline and disorientation. Of note, his transplant was in 2018 as a result of acute tubercular necrosis, which was due to a prolonged ICU stay. And this was all after a very severe motor vehicle crash. And he was on belatacept as one of his maintenance suppressive agents, which is involved in blocking the co-stimulatory pathway and the activation of T cells. It's also important to note that his history is pertinent for recurring UTIs. So the belatacept was recently switched to tacrolimus, and he only received 2 days of it prior to admission. So on presentation, he was alert and oriented only to person. His vital signs were normal. His physical exam, however, did show mild diffuse abdominal tenderness. Besides that, everything else was relatively normal. His lab work was notable for a leukocytosis of 14,000, a hyponatremia of 121, elevated alkaline phosphatase of 543, as well as supratherapeutic tacrolimus levels. His blood cultures grew in Enterococcus faecalis, however, his urinalysis was unremarkable, and at that point, we did not have a clear source of infection. His head CT did not reveal any acute pathology. Further hyponatremia workup, which was done, revealed that this was due to hypovolemia and secondary adrenal insufficiency, which was likely secondary to the setting of his infection that he was experiencing and his use of prior steroids. He was treated with streptosteroids and normal saline, which did improve his sodium, was also treated for his bacteremia, and the tacrolimus was held. However, despite addressing all of the above issues, his mental status did not improve. So an abdominal ultrasound was then decided to be part of the workup because of the abnormal labs and the elevated alkaline phosphatase, and this revealed a very large mass in the right hepatic lobe. An MRI abdomen further characterized the mass, as you can see in the images below. He underwent the biopsy of the liver mass, and the pathology revealed a very diffuse large B-cell lymphoma, which was consistent with post-transplant lymphoproliferative disorder. He also underwent an MRI of his brain, which showed diffuse patchy meningeal enhancement, which was concerning for metastatic disease. Hematology was consulted, who recommended a lumbar puncture and bone marrow biopsy to stage the lymphoma. However, the patient had a poor functional status at that point, experiencing dysphagia, and he had a very advanced disease. So the family decided to pursue hospice care, which they felt was in the best interest for the patient. So post-transplant lymphoproliferative disorders, or PTLD, are lymphoid disorders that are potential complications of solid organ transplants. The incidence can vary from 2 to 20%, more common in solid organ transplants compared to stem cell transplants. The risk factors include Epstein-Barr virus transplantation status. So for example, if the donor is EBV seropositive and the recipient is EBV seronegative, this is a higher risk, as well as ongoing immunosuppressive therapy, which is a hallmark of transplantation. In fact, there is a study which showed higher incidence of PTLD in patients on belatacept who are EBV seronegative and are now contraindicated in that population. Of note, our patients' EBV serologies were donor positive, recipient positive, so it is likely that the belatacept may have played a role in his developing PTLD. So our above case illustrates a complication of transplant immunosuppression and highlights the need to just have a very wide differential when it comes to altered mental status in an immunocompromised patient with a transplant, and being very well aware of all these possible complications that come with transplantation. Although the incidence of PTLD can be quite high depending on the type of transplant, it is quite rare to have a rapidly growing liver mass with CNS involvement with PTLD, and this shows the uniqueness of our patient's presentation. Below are the references used to write this case report, and I'd like to thank you all for your time.